Okay, with regards to the special tests, please remember that they affect more than one structure. They can involve accessory movements, palpatory tests, and neural tests. Accessory movements may involve the slides or the glides or distractions or compressions of a joint. For example, if we look at the subtalar joint, I can be gliding it medially, laterally, anteriorly, posteriorly. I can be compressing it. I can be distracting it. That can be done at pretty much every joint. How it's done is by fixing the proximal point and mobilizing the distal point. And this pretty much goes for stress tests as well. If I fix the tibia and the fibula and then invert the talus, I'm going to be stretching some of the lateral aspect of the talofibular ligaments, and that will give us an idea of his instability. You go by end-feel. I've written a little bit more about end-feel in the course notes. It's worth looking at it, but basically if it gives way a long way, you've got some sort of instability. It depends on the structures you're stressing as to whether they're spongy end-feel, bony end-feel, which is a hard block, or nothing at all, which could indicate some sort of tear. We could try an anterior draw, which gives an idea of the stability of the talocrural joint by fixing the tibia and the fibula and pushing on the talus forwards in posterior anterior direction. We can feel differences between ligamentous integrity, both medially and laterally. As I said, there are different types of glides and compressions. One thing that is useful to do is to look at the lateral ligaments, is to take the foot into plantar flexion and invert it. We'll put a stress on the anterior talofibular ligament. If you feel it's really going across, it could be that it's got a full tear or some sort of tear, and pain is often an indicator of damage to that. A calcaneofibular ligament, the foot is more in a plantar-grade neutral position, again with inversion, and if we can take it into dorsiflexion, we can get the idea of the posterior talofibular ligament. These again, I'm stressing everything on the lateral side. If I'm going to do it in the opposite direction into eversion, I'm stressing the deltoid ligament. Finally, palpation. I just need to check for changes in colour, temperature, swelling, the mobility. Are there any trigger points around the muscles due to guarding or other reasons? Is there tenderness over the bones and the ligaments themselves? The final special test that we can do is looking at the nerves. When we look at nerves, if I can just get you to turn over quickly. When we consider the nerve, as I said, a nerve will often be painful along its distribution. So if we want to look at a nerve and consider that it's possibly involved, if I can just get you to turn towards me onto your side. There are certain places that we can push on a nerve that if it's involved, if you just relax your knee and bring it forward. If it's involved, it will be painful at those points. It could be painful where the sciatic nerve or branches of nerve exit from the lumbar spine. Halfway or 2/3 of the way between the greater tuberosity and the ischium is a piriformis, and the sciatic nerve passes under, through or over that, depending on the person. The bifurcation of the sciatic nerve, again, often tender to palpation if the nerve is involved. The common peroneal nerve, the head of the fibula, and the anterior superficial peroneal nerve over the anterior talofibular ligament often will be quite painful. If I just get you to roll onto your back. If we're looking at the anterior common peroneal ligament, comes down to the anterior talofibular ligament, and we can find the superficial peroneal nerve there. If we want to look at a deep peroneal nerve, by pushing inside between the toe, the big toe and the second toe, between the metatarsals, we can often create a sensation of discomfort there if the nerve is resultant. One further test, again, you need to know what you're doing with this. I don't recommend treating unless you've done the required courses. It can be dangerous. But to get a rough idea of if you're stressing or if a nerve is involved in it or not involved in it, one can take a a straight leg raise, whereby we lift up the leg. That's a straight leg raise. It's usually involved looking at the back. But if we modify it by putting the foot in a different position, we can sensitize and desensitize various nerves. For example, as I straight leg raise, now I'll have to do it on this side, but as I straight leg raise, if I plantarflex and plantarflex the foot and invert it, I'm stressing the superficial peroneal nerve. If I dorsiflex and evert it, I'm stressing the tibial nerve. If I dorsiflex and invert, I'm stressing the sural nerve. They give us an indication of what's going on. I will show you there's different ways of handling. I'm just doing this for simplicity as a basic test. I will take the patient's leg and I will plantarflex and plantarflex and invert the foot. Is there any pain there? And he says, no, yes, it's painful. Now, that could be because I'm stressing the ligament. However, if I bend the knee and the pain goes away, he says, no, it doesn't hurt me anymore. There's only one thing that can be responsible for it, because there's no tendons or muscles that are going all the way up here that are present on the lateral aspect. It can only be a nerve, and it can only be the superficial peroneal nerve. And equally, if I take the foot into dorsiflexion and relax, into dorsiflexion and eversion, take them into straight leg raise and lift them up, and he says there's no pain, there's pain. Bend your knee and no pain, that could be the tibial nerve. Or if I take the foot into dorsiflexion and inversion, yes, it's painful, it could be the ligaments. Take it into straight leg raise, yes, it's painful. Bend the knee, it's less painful, could be the sural nerve. Sometimes you need to combine this with a slump, which I'm not going to show because that can be very aggressive. But you can actually do the same position test with the patient in a position where he slumps, but you have to be very careful with that because you could be setting off the whole of the spinal cord when you're doing it.